Like I haven't been actually through the agenda, so maybe Sudha, you can just continue now.
Ma'am. So as a first part of the roundtable discussion, we have a talk by Dr. PMC Nair about about giving us insight into rare diseases. So why talk about rare diseases, the magnitude and challenges of them. So Dr. Nair, sir. I think sir has not joined yet.
Dr. PM
Sir is joined.
Sir
He has
is there.
joined.
Sir is there.
Magnitude and challenges of them. So Dr. Nair, sir.
Sir is
PMC,
there.
sir.
Yes.
Sir, please. Over to you.
Okay. So shall I share the screen also?
Yes, please, sir.
Please share the screen.
Okay, so very good evening. And question is why talk about rare diseases? So according to the WHO, definition of rare disease is a debilitating lifelong disease or disorder with a prevalence of 10 or less than 10 per 10,000 population. If you look at the definition worldwide, in US it is 0.4, in Australia is the least is 1 per 10,000 population. And as we discussed earlier also, 70 to 80% of rare diseases are genetic and they are known as orphan disease also. So Ministry of Health and Family Welfare launched a national policy on rare diseases on March 2021. And 63 rare diseases have been included under this national policy. Financial support of up to rupees 50 lakhs per patient is provided. And till today, and 1,118 patients have benefited from this. So, and as we said earlier, selected centers of excellence are built, and with pride and happiness, I say, Sri Outtandirnal Hospital, SIT, Government Medical College, which is my own alma mater, is also one of the centers of excellence. And if you look at the issues and challenges, that is my topic. So complex and heterogeneous, between 7,000 to 8,000 rare diseases are reported globally. And if you look at the early diagnosis, as everybody knows, especially Dr. Shankar, it's very challenging, isn't it? Because of lack of awareness, general public don't know much about it, medical fraternity less, lack of appropriate training, very little knowledge about the pathophysiology and natural history. And all this research and public health policy in India are also a nascent stage. So finally, what happens is the particular patient with a rare disease will go to so many places, so many doctors, 2 to 3, even 4 to 5 misdiagnosis, ultimately coming in a delayed stage, poor outcome, and lot of money is spent. In Indian situation, is the high prevalence rate. 1/3 of global rare disease occurs cases in India. Limited clinical trials, lack of definition, low budgetary support, and also public health resources. We have to discuss. We have to balance between the priorities, isn't it? And so probably the focus must be on prevention. Other challenges, as I said earlier, delayed diagnosis, misdiagnosis, limited treatment options, unavailability of drugs, especially therapies are so exorbitantly costly. For example, spinal muscular atrophy, Solgen's genetic gene therapy one costs about 16 crores. So it's impossible even to think about it. Inadequate clinical experience, and also the patient's families suffer a lot of financial strain, psychosocial issues, and for rare diseases have been identified and categorized under 3 groups. A big list. I'll just mention a few only. Group 1 is disorders amenable to one-time curative treatment, that is the hematopoietic stem cell transplantation. Then diseases amenable to organ transplantation, especially glycogen storage disease, MSUD, renal transplantation, Fabry disease. Second group is one lifelong treatment required, but lower cost and benefit is there, especially special dietary formulas like phenylketonuria and galactosemia. Disorders amenable to other forms of therapy like NTBC for tyrosinemia. And the third group is the one where the challenges are there for optimal patient selection for benefit because of the very high cost and lifelong therapy. And all of us remember again the spinal muscular atrophy, where Zolgensma, the gene therapy one cost of nearly 16 crores. One-time treatment, 16 crores. And these drugs also, orphan drugs, limited scientific knowledge about it, difficulties recruiting patients, lack of expertise, significant resources. So probably we'll have to concentrate on prevention of rare diseases, primary and secondary prevention, avoiding the birth of affected children, prenatal screening, all this. All these are very expensive, and also we have centers of excellence for that. As Dr. Diarra said, we should have more centers. So with this background, this is the Rare Disease Day tomorrow. Today we are on the eve of it. International awareness should be created. And actually, even I came to know much later only about this rare diseases. And February 28 is the day for rare diseases. They aims to educate equity of care in healthcare, diagnosis, and access to therapies for people with rare diseases. And NNF Kim CSR project. It's a great blessing. Help means help to evaluate and live to full potential. National policy for rare diseases, and it's good that the NNF in the first action plan itself has taken it as important thing. With the help of Kim CSR, we'll be definitely able to help these babies, help to evaluate and live to full potential. Because previously we are just sending them home without much hope because we didn't have money. Okay, so thank you very much for that. Just short introduction, 5 minutes. Thank you.
Thank you, sir. To introduce sir, he is one of the first formally trained neonatologists of India and our teacher. Thank you, PMC sir.
Thank you.
The next speaker for the roundtable discussion is Professor Orna Starets-Kekam from Israel. She is a senior most neonatologist and a metabolic specialist. Over to you, Professor Orna, for discussing regarding the challenges and potential in setting up services for infants with rare disorders.
Orna?
Ma'am, over to you for taking up the discussion.
Can you see my screen now?
Yes, Professor.
You see my screen, right?
Yes, ma'am.
Okay. 1 second, sorry. I started from the end. 1 second. Sorry. So good evening, everyone. Sorry for the wrong issues. Thank you for the kind invitation. As you heard, I'm a metabolic specialist and I also work in neonatology as a senior neonatologist. And we have a lot of rare diseases in the area we serve. I'm from the southern part of Israel. We have a unique community, I'll show you very soon, of the Bedouins. And this is a unique community with a large amount of rare diseases. So I have no disclosures. And I wanted to start with 2 cases just to show you what we deal with. So the first case was born as a term AGA, had persistent pulmonary hypertension, which necessitated oxygen for about 6 weeks, which he was hospitalized. Later, he developed coarse faces, very, very dry skin. And to make it short, we diagnosed him with multiple sulfatase deficiency, a very, very rare disease, prevalence of 1 to 1 million to 1 in 2 million. Well, while I was asking questions and taking history, I found out that actually another patient of mine is his cousin. Before he was diagnosed, every time I asked whether they know someone who's sick, affected with anything, nothing. Then we found out that they were cousins. So that's one patient. The second patient I want to tell you is the patient who was born term AGA, after an uneventful pregnancy, was discharged as common here around 36 to 48 hours from the hospital. And at 4 days, she was admitted to the PICU with severe hypoglycemia, almost in a comatose state. And at the same day, like 2 hours later, we got the diagnosis of newborn screening. In Israel, we have the expanded newborn screening. And she was diagnosed with very long-chain acyl-CoA dehydrogenase deficiency, which is part of the fatty acid oxidation defect. 2 years later, the mother delivers another baby without any prenatal testing performed. And we can have prenatal testing either as CVS or amniocentesis. And we can also offer PGD, but none of it was even discussed. And what's common to these two patients is both of them are Bedouin origin, and in both cases, the parents are first cousins. So two major obstacles we deal with, and it results with a lot of rare disease patients, is consanguineous marriages, and also, as you can see in the second case, in a way, lack of faith in medicine or lack of prenatal testing, which is a major problem in our area. So when we come to deal, and most of the things I'm going to say were actually said by the previous presenter who really summarized everything I'm saying. So we have a major issue with delayed diagnosis due to lack of awareness. And we know that in babies or kids, the diagnostic odyssey can take in a mean of 5 years, which is a lot if you think about it, especially since these diseases are so complicated and the earliest diagnosis can lead to a crucial time for treatment. So we miss a very, very long time of treatment. And the general lack of awareness is everywhere, I would say. So whether it's from babies to adults, and people, if we won't raise the awareness among healthcare professionals, of course, the public won't even know about it. So that's one of the major obstacles I think we all have around the world. Again, limited expertise. If I tell you how many, well, Israel is a very small country, 10 million people only. Excuse me? Okay. So Israel is a very small country. We only have 10 million people, but still we only have around 40 metabolic specialists. So if you think about it, it's a very, very, we don't have enough experts in the field, which could also not only raise awareness, but could diagnose the patients earlier as needed. Also, what we need because of these complicated diseases or multisystemic diseases, we all need a multidisciplinary approach, meaning we need a bunch of different fields, specialists coordinating, working together, and we don't have that in most places. Access to treatments, that's one of the major issues, I think, everywhere in the world. First of all, many rare diseases still lack approved treatments. For example, we had a baby this week, born at term, so-called everything was fine, but then developed a severe lactic acidosis. And a lot of times in our area, we diagnose patients, it's funny to say, it's sad to say, but by the name. So the minute I was called about this patient and I knew the name, I knew the diagnosis, and it was unlucky, it was true. But even though we knew it, if you think about it, on the first day of life, we still couldn't offer treatment because a lot of rare diseases still lack approved treatments or treatments at all. Not only that, as mentioned before, the cost of treatment. When someone develops a treatment, and the colleague that talked before me said about the Zolgensma, which is the treatment for SMA, the gene therapy for SMA. But if you think about it, at least gene therapy is given once. So it does cost above $2 million, but it's still one time. There's a new drug that was just developed for Niemann-Pick C1, which costs per year about $1.2 or $1.6 million. Imagine a patient, how can you get a drug that costs for like this amount of money? Only if you're richer than God. And the second issue is, I don't see how, at least in Israel, maybe in other countries also, how will the country can afford putting it in the basket, so in the health basket. So it's a major issue. Also, we need to be able to have pharmaceutical companies be interested in developing therapies tailored to infants. A lot of times, drugs are developed, they're on clinical trials for adults, which means you can only start them even if they try for adolescents or maybe children. Most of the drugs are not for infants. So that's another issue. We need to think about it. And as said before about how expensive it is, as my colleague said, the gene therapy for SMA, which is around $2 million per patient. There is limited funding due to the rarity of the diseases and the low number of patients. Many pharmaceutical companies won't be interested because you develop a drug, you want to get profit. And if they're such a small amount of patients, you won't get the profit you want. So many people just avoid going into these fields, and we need it. Limited resources delay the establishment of rare disease centers with recruitment of trained professionals. And I think that's the main issue we need to establish in every place, whether it's rural or not rural. These patients face so many challenges accessing clinical trials, even getting to know about it. They need better awareness of all of us for that, and especially if they come from rural places or faraway places. We had not long ago a clinical study of urocycle disease patients, which was canceled because the number of patients, it wasn't only canceled as our site, but it was canceled in the world because there were not enough availability of patients. So think about it. What about the patients that do exist? Because they exist. So it's a very, very important issue. I think we need to help patients navigate with all the systems, the bureaucracy. We are trying now, at least in Israel, we have a committee that works as specialists with the Ministry of Health to try to find ways to make their lives easier regarding all the bureaucracy, all the forms they need, all the visitation. And I think one of the issue, again, it will be to make their life easier, meaning you can come on one day and see your pulmonologist, your orthopedic surgeon, your neurologist, and so on. Another barrier we have, and I guess I would believe that in India, from my short visit there, patients living in rural or underserved areas. And as always, these patients are the ones that tend to be with rare diseases. So we need to find a way to get them to closer rare disease centers, because mostly rare disease centers are located in major medical centers, and that's not where they live. And I chose to show you pictures except from our area, but this is a picture from Google, so we didn't need any additional approval. You can see here a patient living in a shack, and you can see the area, and I think that's one of the only places in the world with the sign "Beware of Camel," because that's the desert, and that's a desert in southern Israel. And you can see how these people live, and you understand how desperate they will be for services or access to medical services. I think, as I said, one of the solutions would be centers for rare diseases. Family stress. These people live with so much stress and demands, because taking care of your child when you see that he has so many issues is a psychological stress and burden for the family. Therefore, we need to develop a really very, very good support systems for these patients. Again, what we face, and advocacy groups are one of the major supporter for the patients themselves, and also for getting drugs into the health basket, or promoting developing drugs research. And I saw that with the multiple sulfatase patients, one person from Ireland who developed an advocacy group and fights all over the world, and research is done. And also the way that, at least in Israel, the Zolgensma got into the health basket was due to the very, very strong advocacy group for this disease. One of our obstacles here in the South is that the rural people were also uneducated, and therefore they are not part of advocacy groups. So if you don't unite as a small community of patients with rare diseases, you cannot achieve what you need for your affected ones. So awareness, training, that's something that the country has to help with it. It's not enough that healthcare professionals or the specialists do. It has to be as part of a policy and training, and also advocating for policies that support funding and access to treatments with establishment of the specialized care centers. So to summarize, I think the approaches to addressing all these challenges that we both actually talked about is international collaborations among researchers, healthcare, patient groups to bridge the gaps in knowledge and treatments that are available. Telemedicine can connect patients with specialists all over the globe. So that can be overcoming the geographic barriers, because sometimes the best specialist would be in a different country. If you have telemedicine, you can overcome it. Governments, of course, because they can create incentives for pharmaceutical companies to try to develop the drugs. For example, tax breaks, grants, exclusivity, all these stuff that can only come from someone who's running everything. And again, developing care models such as what I said, centers for rare diseases that involve, and also that care models that involve patients and their healthcare providers, so that together they take the decision and it kind of becomes a holistic well-being of the patients and their families, because the families are so important as a support and treatment. And thank you. And if you have questions, I would be happy to answer.
Thank you, Professor Orna. I think you have echoed your experience, which is at least 10 years ahead of what we wish to do in a larger country in terms of population.
Sorry.
And I just take one line from you, is that every step made by every single individual, an expert, a financial supporter, government, is going to be the next step towards a better life for these children and families. So we'll hear out our experts and we'll request you to stay, because for another half an hour, there may be a lot of specialists, pediatricians and neonatologists who may have questions to ask you. So thank you for your presentation.
You're welcome. Thank you.
I will invite now Dr. Uma, who is our expert in metabolic disorders, and I have no doubt in expressing that there are a lot of people who are interested in metabolic disorders in India, real good experts, but they all start working with children who are older, and we as neonatologists really have little help available when it comes to advice. Uma is formally trained in neonatology, an avid researcher, a passionate clinician, and formally trained in metabolic diseases as well. Over to you, Uma.
Thank you, sir, for the kind introduction, and thank you for the opportunity. So, is my screen visible, sir?
Yes, Uma, clear.
Yes.
My topic is on potential of managing metabolic disorders. Thank you, Naveen, sir, for the kind introduction which you have given about me. Basically, I'm a neonatologist, but my special interest for metabolic disorders came because we started counseling antenatal women. And when we were evaluating the infant children, most of them may not have been evaluated completely. So we could not offer what is to tell for the present pregnancy. So that is how I branched into from perinatal to the metabolic division as such. So this is if someone is going to think that rare metabolic disorders are rare, I may not see. So this is the spectrum of metabolic disorders which we have seen in the clinic, which is a 2-year data. If you see here, you can see every condition what is mentioned in the Nelson or any standard pediatric book placed here. So we had like few children in every condition. So I'm sure this is the same thing with others as well. So it is that like we need to be open about evaluation. So to put up how rare they are supposed to have incidence somewhere from 1 in 50,000 to 1 in 5 lakh. But like a 2-year data clearly says that they still are existing there among us. So these are our metabolic stars. We know that newborn screening is a way forward because even before the baby develops symptoms, it is going to tell us about the condition. So, phenotype of iceberg, as explained by James Pitt, before clinical diagnosis is made, newborn screening is a way forward. So, we have experts in India who have worked for this newborn screening. So to go to the details of like misconceptions, I want to take to throw some of the misconception which is widely prevailing. So we take it as inherited metabolic disorders are rare. In a way, maybe, but individually rare, but collectively common. So we have a lot of conditions. So put together, they became common. IEM should be considered only when there is a positive family history. I do not agree because majority of them are consanguineously married and it is an autosomal recessive disorder. So it might give us a clue. So there need not be any positive family history. Sometimes you do get a positive family history, but not necessary. So IEM mimics sepsis. Yes, very true. As a neonatologist, our first and foremost diagnosis in any sick neonate presenting with lethargy will be sepsis. But IEM mimics sepsis. Have to consider IEM workup if the baby did not really have any risk factor for sepsis and sepsis is not fitting in. And also we need to remember that some of the IEMs like multiple carboxylase can be associated with candidiasis. Galactosemia can be associated with E. coli infection. So it can be coexisting. So someone might think that it is difficult to remember each presentation. I would also agree with it because it is impossible for each one of us to remember all the pathways, but better to go for an algorithmic approach and going from a broad screening test to a highly specified test. So some might think, okay, only few are treatable, so why to spend so much of effort in something which you could not fix? But that is not true. There are a considerable number of conditions, metabolic disorders, which are treatable. So among genetic diseases, IEM is considered as treatable. So even in the countries who regularly do screening, they still find metabolic disorders when they are evaluating developmental delay children. Definitely it is treatable. And what do we tell parents who are eager, like waiting outside the NICU? Everything, birth history, everything was fine, but suddenly baby is sick and baby is shifted to ICU. So for counseling the parents and also for formal genetic counseling and to evaluate the future pregnancies, we need to diagnose IEMs. So TMS is considered as diagnostic. So once you are suspecting IEM and you do a tandem mass spec and like people consider that as a diagnostic, it is not true. So there could be other evaluation which might be needed on an individual basis. It could include plasma amino acid, urine, GCMS. Breastfeeding is contraindicated. This is one of the misconceptions which is prevailing very commonly among neonatologists and pediatricians. So they tell the parents that like breastfeeding is contraindicated. That is not true. Breast milk has a nutritional advantage and all the amino acid levels are lower compared to formula feeds and it should be started as early as possible after crisis. Even if we are putting on specialized diet like special formula, only a proportion of milk should be breast milk. So 40% or 30% should be breast milk and the rest of the thing should be a special formula. So this I already answered. Will I ever see a metabolic disorder? The answer is yes. Among protein, carbohydrate, and lipid disorders, protein disorders presents as intoxication. That means it slowly builds up and causes effect. And they present in terms of lethargy, encephalopathy after a symptom-free period. whereas carbohydrate and lipid disorder presents as energy production or energy utilization disorder. So if I have to categorize these disorders, I put it into 3 baskets, namely group 1, intoxication group. So they include protein, majority of the protein metabolic disorders, or some of the carbohydrate like galactosemia. Energy failure group 2, and which include lipid metabolic disorders, carbohydrate like fructose 1,6 and mitochondria. Group 3 will be storage and vitamin responsive disorders, where I put in all the lysosomal storage, peroxisomal disorders, and pyridoxine responsive. So if you have to categorize this, these are treatable intoxication group. Lipid disorders and carbohydrate fructose 1,6 is treatable, and vitamin responsive disorders are treated. So you have quite a number of disorders which are treatable as such. So presentation in newborn can be in any of these, A, B, C, D, you can remember easily as acute encephalopathy, bacterial sepsis, cardiomyopathy, dysmorphism, enlarged liver, etc. So when we evaluate, we do what is known as acronym as GALAP, which is glucose, ABG, lactate, ammonia, and ketones. Along with that, we ask for plasma amino acid, urine organic acid, TMS, and enzyme assay. So of course, a majority are autosomal recessive disorder, or sometimes rarely it can be X-linked. So molecular analysis is mandatory. So I'll just quickly go through one of the case scenarios which we have seen. So this is a day 17-old baby who presented with encephalopathy. Even though the working diagnosis was acute bilirubin encephalopathy, something was not fitting in. The sensorium deteriorated, needing ventilation. Even though MRI showed basal ganglia hyperintensitivity, we felt that something is not quite fitting in. The baby had vomiting on and off. So we wanted to do a GALAC workup, which stands for, so the glucose was 90 with the ABG showing acidosis, with the mild lactic acidosis, and the ammonia was very much elevated with the 289 micromole, and ketones were positive. So all of us know that you can take a quick card, help of this quick card, we can put this into the basket of organic acidemias. If we do not know, we can take even the algorithm, because this is a neonatal hyperammonemia presenting after 24 hours, and there was acidosis. It is again fitting into organic acidemia. So algorithms do help in kind of evaluation of IEM. So the BUN was elevated, which is again against the diagnosis of urea cycle disorder. We went ahead with tandem mass spec, which showed an elevated CP, and the urine organic acid profile, which is suggestive of propionic acidemia. So baby underwent peritoneal dialysis, and also ammonia scavengers were started. So the ammonia slowly, like over a few hours, came down to normalized, and also the sensorium improved. So if we have to, this is one of my favorite slides, like if we have to apply the management's principle of IEM for this propionic acidemia, we can decrease the substrate by putting on low protein diet. So that means on follow-up vegetarian diet, initially will be breast milk along with some of the energy dense formula, and also metronidazole, which will be 7 days a week to reduce odd chain fatty acids. We could increase the disposal of toxic metabolites, or we can increase the enzyme activity. So IEM and diet are like inseparable combos. They would not kind of, you have to know about diet treatment if we are dealing with IEM. So as I said already, there will be a proportion of breast milk along with that special formula. Now, like we do have low protein biscuits or low protein flour, which mother can use. So this exome sequencing proved a homozygous mutation in PCCA gene. Baby was managed with the predominant breast milk along with special formula. And infancy until 2 years, baby had vegetarian diet. Baby was thriving well. However, baby did develop some metabolic crisis. So underwent liver transplant, and after liver transplant doing well. So this is one of our child who got refractory seizures, pyridoxine dependent seizures, doing well. This is a propionic acidemia who underwent liver transplant. He is one with MCAT deficiency, and he had diagnosis of biotin-based deficiency, and she is a child with the VLCAT deficiency with previous neonatal death. I have got permission from the family to show the pictures. So questions to answer. So, should you consider diagnostic evaluation of IEM, and is it available? The answer is yes. Is there availability of special formula or diet, or do we have access to advanced modality of treatment, namely liver transplant? The answer is yes. Is there expertise available to guide on to the correct path? I think yes. I would think that the health project is going to take it there where we want expertise to put us on correct path. Thank you.
Thank you, Uma. Please do stay on. I know we gave you very little time, but you have at least answered the FAQs. I really hope we can convert people. It will take time, despite of the communication and information, to say that a rare disorder fits into the 3 questions and answers that you gave us. And I would like to invite, because we want the question answers to be there at the end, other colleague, young colleague, Dr. Roshan, again, a rare expert because he's a pediatric geneticist trained from the best institute of the country from PGI Chandigarh, very passionate, always available, and I have seen him to have such crystal clear communication that I'm a fan of his. Roshan.
Thank you, sir, for the kind words, and thank you again for inviting me to the session. Is my screen visible? And I hope I'm audible.
Perfectly, Roshan. Please go on.
Okay. Okay, so my presentation is very brief, and I'll just be going through. I just want to dive home a couple of points. One is the rising therapeutics that are there in the genetic disorders, and when you should consider a diagnosis of a syndromic diagnosis or a genetic condition. So, one of the first points that we would think is that genetics has been there since the evolution began, right? So why is it that now that we are talking about it? Because genetics and genetic diseases have been there since centuries. So the thing is that we are currently at the midst of two breakthroughs. Okay, one is the breakthrough in diagnostics and one is the breakthrough in therapeutics. That is why this is extremely important at this particular point. So in diagnostics, we can see this that just a second. So we can see that a test which used to cost around $100 million around 20 years back, around 10 years back, it just cost $1,000. So this has been the drastic drop in the cost of diagnosis. It's mainly because of the new technology, that is the NGS, next generation sequencing. This cost has even come down now to around $500 to $600. So this has enabled rapid and cheap diagnosis for us, which was not earlier possible. And again, in therapeutics, if you can remember our basic biology, within the cell there is the gene, and gene that is the DNA level, it leads to RNA production and then to protein, and the protein does its functions. And if there is any problem at any of these phases, it leads to the disease problems, right? So till around 20 years back, we only had one management for this at the level of the manifestations, that is supportive treatment. That has been the traditional treatment. But again, the other breakthrough is in the therapeutics, where now we have different therapies at all of these levels. We can change the cell by stem cell transplantation, right? We can change the organ transplantation there. We can change the gene or change the errors in the gene. We have RNA based therapies, we have protein based therapies, and for many diseases we now have small molecules or disease specific drugs also. So now that we have a cheaper method to diagnose this, and now that we have therapies to counter these diseases, this is why we are now talking about rare diseases rather than any time else in the future or in the past. Okay, so early diagnosis is really important now. This has already been covered. So the thing is that it helps in obviously the early timely intervention, and it obviously leads to better outcomes. This is especially true in case of IEMs, like Dr. Uma ma'am has already discussed, and also in inborn errors of immunity or the primary immune deficiency that we used to call earlier. And it also helps in preventing complications and disease progression. In many cases, the One of the major modes of management is surveillance. Every 6 monthly, we have to do a hearing screen or a thyroid test or a MRA or something like that, or an echo. And the disease, with time, it will progress or it will evolve. And if we are doing a surveillance, we can detect them early and prevent the progress or complication. And also, it helps in counseling in families. Right now, also, Naveen sir might be knowing, we have a family who has whose baby has a couple of anomalies. One is the spinal anomaly, and one is bifid ribs. So now they want a diagnosis of what the problem is and how it will evolve and what the prognosis is. And usually we see a condition called spondylocostal dysostosis, and we are suspecting that in that baby. And usually they have good neurodevelopmental outcomes. So we hope that the baby might be having that, but only a genetic diagnosis will help us make sure that the diagnosis is that, and we'll be able to tell the family that that is the correct diagnosis. And usually it won't be affecting the neurodevelopment, and otherwise the baby should be fine. But unless we have a genetic diagnosis, we are not sure if it is not any other rare form of the disease or a ciliopathy or something like that, which can have a grave prognosis. So again, diagnosis is important, and obviously it can prevent recurrence. So in many cases, when I was in PG also, what we used to do was that whenever a baby has expired before with suspicion of a genetic disease, we used to ask them if they have saved a code, the fallen cord, umbilical cord they used to save, right? And many of them would have the umbilical cord saved with them. It would be dry and all, but we would be able to still extract DNA from that sample and still reach a diagnosis. But many times the baby would have expired within 7 days. That is, they did not even have the chance to preserve that fallen umbilical cord. And so again, that is the condition in which many families come to us. So at such scenarios, if we want to give them a hope that such a condition won't be recurring again and all, the earlier the diagnosis, the better. And once we have a genetic diagnosis only, we will be able to offer that to the next future pregnancies. And again, a few examples: Diger syndrome, if we are seeing only a dysmorphism, and a cardiac disease, maybe the baby might otherwise expire of immunodeficiency later, but if we can find it early and give them the appropriate this vaccinations and all, maybe we'll be able to save that baby. Again, craniosynostosis syndromes, the baby might be born just with the abnormal head shape, and it might be missed, but later down the road that baby might develop increased ICP and might develop herniation and can be life threatening also. Again, IEMs, the stem cell transplantations might be useful sometimes, and sometimes lifelong IVAG or prophylactic antibiotics and etc. can help prolong the life and also the better quality of life in such babies. So this is one of the main points that I want to discuss, just the cheat sheet on when you should consider a genetic disease. This is not getting to IEMs. Dr. Uma ma'am has already discussed that. So whenever there is dysmorphic features, not just the facial dysmorphism, but any other cleft palate, the thumb anomalies, limb anomalies, everything can be counted as a dysmorphic feature. Congenital major organ malformation, even if there is one major organ or two or more minor anomalies like polydactyly is there, additional nipple is there, or some minor anomalies are there, but two or more, or even if a single major anomaly is there, you should suspect a rare genetic disease. Neurological signs like hypotonia, all those you can see. Growth or abnormality, especially at birth, IUGR, microcephaly, etc., can be there. And family history, especially if a previous sibling is affected, or a consanguineous marriage with some particular feature or a single feature. Instead of thinking of a common disease, maybe you can think of a rare disease also. And in newborn, the universal newborn screening also, sometimes we pick up a lot of findings. And one of the major things is that persistent or unexplained symptoms. This we seen in adults also. Often genetic disease, when we come to the diagnosis or a suspicion of a genetic disease, when everything else is ruled out. So this also, we had a baby Maybe I think Naveen sir would remember we had a baby who was persistently on ventilator requirements, but he was not fitting in the definition of BPD also. All the other causes were ruled out, and then we did a genetics. I think that came out to be normal. But again, if all the other workup is negative, then again we should think of a rare genetic disease. So once we suspect a genetic disease, what next? So the next thing would be to select the appropriate test, select appropriate workup and appropriate genetic test. And after the test, if it is positive, the management of the rare disease proceeds. If it is negative, then again, how to deal with a negative disease. Sometimes the report is ambiguous, and sometimes the couple would need genetic counseling also. So this is where the role of a rare disease expert or a genetic clinical geneticist would come. So at least some of these is what we are planning to cater through our health project. And Naveen sir, today we met in the morning, and he specifically told that this health project and everything is only a temporary solution. At the long term, if we want to improve the quality or improve the diagnosis and the outcomes of rare disease, we need to raise awareness. So, as part of the Rare Disease Day celebrations here, so we had made a few flashcards of common rare diseases, and Naveen sir had suggested that we can circulate it among the members of the NNF also. And I think the digital app that you are launching also, we would be happy to share so that it can raise some awareness on the common rare diseases. So again, this is my concluding remark is that the rare diseases and the genetics field as such is evolving. More and more things are being tied to genetics now, and the genetic testing cost is rapidly coming down, and even the treatments, just like the immunotherapy or the many other cancer therapies which used to cost lakhs earlier now has come drastically down. And the next few years we will see the same thing happening to genetic therapies also. At that point, it is important that we start frequently suspecting these diseases so that at least some of them would actually turn out to be rare diseases, and we can offer a meaningful solution to them. So this genetics as such is a paradigm shift in how different diseases are being checked. So it is important that we evolve with this, and we respond to this change so that we can be better clinicians in catering our care to the babies. So that's it. Thank you.
Thank you, Roshan. Like you said, I would like the most powerful message you gave was in raising awareness. That is going to be the first step. Unless we start thinking that we are facing a rare disorder, we will not ask for help. And then the second step would be to drop our shyness about asking for help, to not worry about cost, not worry about knowing experts. For the want of time, we'll come back and ask you more questions. And next, we have the most important person actually, because once you have made a diagnosis, let us say, we only give 50,000 rupees. Suddenly somebody asks me, just 50,000? What will you do with that? Now we have a diagnosis. What next? What do we do? So that is where the government of India is already standing there, and not many of us will be knowing that up to 50 lakh rupees can be obtained, expertise can be obtained in centers of excellence. And I have Dr. Shankar, my senior, my mentor throughout my journey in pediatrics and neonatology, who is trained from SGPGI as a geneticist and currently has taken the step, and Professor Orna, which you were saying, is to convince the government of Kerala to take and the government of India to take major steps in improving rare disorder work. Shankarji, to you.
Thank you, Naveen. I think I am audible.
Yes,
Yes,
you
clearly.
are.
Okay. Thank you, Naveen, for the kind words and for the opportunity. Thank you, Manoj, for taking this very good initiative as an NNF First Presidential Action Plan. Thank you, Kims, for taking this initiative because it is in the eve of Rare Disease Day. So somebody has told Rare Disease Day is tomorrow, 28, just after my DM in 2007, when we are observing Rare Disease Day in Chennai. We are a very handful of people with 10 or 12 consultants throughout India and around 30 to 40 patients. And nobody knows what is Rare Disease Day. Only some people are doing them some activity. From there, in last 17 years, things have been changed in a large way that even governments are observing Rare Disease Day. Last year, Government of India has had an excellent 2 days workshop with the WHO in Udaipur, where all of us are attended. So thank you for the entire healthcare community to helping increase the awareness of the rare disease. So actually, my all previous speakers has given a narrative. What is rare disease? What is NPRD policy? What is the international arena? And how the metabolic diseases and my young friend, my student, and my, what you can say, Roshan has beautifully explained regarding the genetic diseases and management. Now we will come to the what actually the Center of Excellence. The Center of Excellence, as the Professor Orna told, it's only a center for rare diseases. Because people have asked, what is excellence? Actually, they have put the word Center of Excellence because for giving the status of management and diagnosis of rare disease, they have put some criteria. Checklist has been created and various institutions they have visited throughout India and to check for what genetic trained person is there, basic facility for genetic diagnosis is there, multidisciplinary care management options are available. All these things has been checked in government institutions basically. And they have given first 7 institutes as given, that is all central institutes only. Then it has extended to 11, then 12. Now it is recently Imphal, one more regional institute. Imphal is also included as a 13th Institute of Center of Excellence. And basically, they are planning to start one center of rare diseases in every state, minimum. Every state, minimum one center of excellence. That is the central government plan, and they are going with that. And some of the institutes are also given request for Center for Rare Diseases. And if you got a status of Center of Excellence for Rare Disease, naturally you will get some benefits from the central government for both infrastructure development as well as treatment of rare diseases. And infrastructure development is a granted aid scheme for developing some more investigative facilities. That is a one-time grant of 5 crores will be given. That depending upon our requirement, we can submit the proposals and they will be releasing the amount. And about the treatment purpose, we have to register the patients. And there are some typical forms are there, Annexure 4, Annexure 5, some consent forms, all these things are there. So if you diagnose some rare disease, as Naveen told, through this program, the neonatologist or the clinician should refer these patients to nearest center of excellence for rare disease, where they can be registered. And most of the centers having a protocols are uniform, the forms are uniform, but only thing is their OPD days and other things, maybe some differences may be there, where to attend, how to go about, all those things. And you have to register, and the technical committee in the Center of Excellence will be evaluating that case and make sure that that patient required the specific treatment like liver transplant or renal transplant or the dietary therapy or enzyme replacement therapy and so on. And Sarah has told about the 63 diseases in 3 groups. And that means whatever you diagnose may not be coming to the purview of the rare disease for funding for 50 lakhs. That for 50 lakh support and all these things, they have 63 diseases has been included under the 3 categories. But these 63 diseases are dynamic in nature. That means previously it was not 63, it was only 51. In last 2 years, with various meetings and requests from the various places, one by one the things has been included. And even now, if somebody has identified a disease which is having a treatment is available, and that can be included. And why this 63 and what is the criteria for including the disease? Basically, it should be a reasonably prevalent disease and there should be a treatment available and that should be reasonably approachable, means cost should be affordable. And group 3 diseases, still there is a lot of confusion is there even among the policymakers because that has been included, but that is not sustainable. That means in gene therapy, risdiplam therapy or enzyme replacement therapy, even with 50 lakhs, we will be able to give the treatment for 1 year or 1.5 years or 2 years. After that, what will happen? It's a big question mark. But there are so many discussions are going on. I think policy may have some modifications to give a lifelong therapy or this 50 lakhs may increase to 1 crore or something like that.
make our case very, very strong. When we pause it, no, he should not have.
So these type of changes or dynamic changes are also happening in the NPRD policy. So all of you, what you have to do is you don't have to check whether this treatment, this disease is included in the rare disease policy for management. Even if it is not included, it is better to refer to a COE so that we will be able to know that these type of diseases are there, treatment is available, people are requesting it, so that we can start the proceedings. That for that there is a separate protocols, SOP, etc., which I don't think other people wants to know, because there's a separate set of forms are there where we have to submit to the central government ministry, where there's a technical committee is there, CTCRD is there, where they will discuss the issues for including that disease and the treatment into the rare disease portfolio. But there are so many diseases are coming on that way. There are so many applications are there. Things are moving it. But I think it is a very, very great initiative from the KIMS, so that for the diagnosis in this policy, there is no funding support. Because in principle, this diagnosis is the responsibility of the Center of Excellence, because they are checking it whether you are having a diagnostic facility. But as everybody knows, in India, there is no center where all these facilities are available. If reasonable facilities are available, they will give the Center of Excellence facility. But there are some lacunae are there. Some tests may not be there. That test we have to be outsourced. So a project like this, which will help you definitely, especially in newborn, definitely we will be catering the IEMs. We can diagnose the IEM, which definitely start early. I have discussed with Naveen also, because first 6 weeks treatments or 8 weeks treatment also, if possible, to cover in this project. Because whenever it is come to central state government, they have to register. We have to have a technical committee report. Then we have to procure the medicine. All this will take little bit time. We cannot, if they come today, tomorrow we cannot start. We are also managing this through some agencies. If possible, patients will take for 6 weeks or something, they will take the diets. Or very poor people, we will use the Supran fund or some other fund for few days for helping them. So that is also a good idea, where the dietary therapy, where immediate therapy is required, a gap therapy can be included in this program, so that the continuation of therapy can be taken up by the government system. These are some of the things I want to tell. And any doubt is there, I can discuss. And this also very high cost is required. Last year it was 140 crore was the government budget. As far as I am knowing, next year government is planning to invest on 940 crores, 940, for this treatment purpose. Still, I think it is not enough, because there are so many court cases are there. Recently, an SMA case, when we have calculated the cost of SMA treatment, it is somewhere around 3,400 crores for India to manage all rare diseases, because it's a very huge cost affair. And government is also expecting funds from the common man as well as CSR, because it is like that. Because inside the rare disease, if you go to the government of India site, you can donate into that. You can donate to the particular patient. You can donate to the particular center, saying that this much money has to be given to this patient for treatment purpose. So naturally, this will be long-term sustainable only with the help of the people in India as well as the CSR. But CSR, we are not getting CSR into this, because CSR wants to give for the specific demands, not generally given to the government sector. We have gone to various CSR, discussed with various CSR people. But I think common man can give some forms of funding into that, so that we will definitely get a good funding in future itself for continuing sustainability of the management. I think I have covered the most of the area, but I want to tell. Rest of the thing I will cover when there is some discussions are going. Thank you, Naveen, for the opportunity.
Thank you, Shankarji. I know that it's so close to your heart that asking you to tell us in 5 minutes is very challenging, but at least you told us that there are multiple crores of rupees and not just this 50,000 rupees that is there. Now, there are questions which are coming to the minds, and I'm happy that they're coming.
Before we go on to the questions, I see in the panel of attendees, there are some distinguished guests, like a doyen of neonatology, Dr. Hilary White from SICKIDS. She was I don't know right now whether she is, but she was the director of SICKIDS International Outreach Program and all that. So can I request Dr. Hilary White if you could join as panelist, and then so that we could request you to speak a few words if you are. I see you are around.
She's there around. I have invited her as panelist, Manoj.
Yeah, she is joining. She's joining. Dr. White?
Yeah, thank you. You are too kind. And yes, I've been listening
It is so
intently.
nice of you to join. I did not notice you initially. Yeah.
I've been listening intently. Obviously, this is an area where we all seek improvement in practice, early identification and doing what's best for the patient. We operate in a different healthcare system, as you know, where the government pays, the taxpayers pay the government. So we are aware that these treatments are extremely expensive, but it's not come up as a barrier, to be honest, to patient care. Not so far. But we are very definitely enlightened as to the cost of these new therapies. And hopefully, as with the cost of genetic analysis, pardon me, we will see an improvement over time and these costs coming down. It's very much driven by the research and development required for the interventions. I'd be happy to join as panelist. I really don't have anything to add because it's been a very comprehensive discussion thus far. So thank you for inviting me to join. And if I do have anything worthy of saying, I will certainly put my hand up.
We will contact you again, madam. Thank you. Naveen?
Manoj, I'll close the session by repeating the process again, because that is
there are some questions before you close.
Yes. The questions are pertaining mostly to the process.
By the panelists, and then Deborah raise a hand and all that. Yeah, please go ahead.
Yeah, we'll come back to the questions, and because some of the questions might get answered in this 6-7 minutes that I'm going to take.
Okay.
We have all heard this word help again. I'm not going to repeat. What we know for sure is that we don't know. We are pediatricians. We know how to manage maybe a given disease, an illness, infections, shock, ventilation, newborn specialist, hypoglycemia. But after that, we don't know. And what do? We are standing in the middle of the ICU, facing a parent outside. How do we do? So that is where we are trying to look at who will benefit from this 1 hour that you attended and heard us out. Who are the beneficiaries? I know Shankarji said we need to extend beyond 1 month, but I think it was selfish. It was project launched by neonatology, so we stuck to 1 month for now. How do I ask for help? You are an NNF member, reach out to DGNNF. If you are not been able to find DGNNF, there is a hotline number. Just send a message, I need help. And then tell us whatever you know. The baby has hypoglycemia, baby has shock, he's encephalopathic, I suspect there is something unusual. Talk to our team. And then there was a question in the panel, Manoj, which said, how will samples be collected? As soon as this information comes to Uma, Shankar, and to Roshan, if they feel that you will benefit by investigating a metabolic or genetic disorder, they would send an email to the CSR office. And we have even put a time plan that within this many minutes, the CSR office would immediately forward the message to either the metabolic team, the lab, or to the genetic team, which is already having tie-up with KIMS, a long MOU. It has been processed for 1 year, already oiled and run. The process has been working perfectly well, except one thing. 10 lakh rupees were allocated by KIMS CSR. We only used up less than 1 lakh of rupees. We want more people to use this expert. So all you will have to do is tell that I have a problem. Within 1 or 2 days, the lab will reach out to you and pick up the sample. What is the interest of the lab? They're getting more samples. Hardly anybody is asking them to take samples. They will be paid at the same rates what they were getting by the CSR team. What is the benefit that the patient gets? They get a confirmation of a diagnosis. Some of them may have a next step, a solution. Some of them may not, but they need to know what is the diagnosis they're facing with. So if you already have a rare disorder and you want more money, currently we cannot give because Shankarji is willing to give that money through Government of India. What is not covered, like Derari sir asked, we cannot cover their milk, food cost, transport, because we would run out of all the money and the rare cause disease would be completely defeated. This is the whole team, and we have champions here who are going to add to the list. We want the bigger team to be there, Manojji. Each state should have a member, a champion, who will remind others that there is a process like this. So I'm going to ask Ajay to slowly and clearly explain the process flow before we hand over to Manoj and team. Ajay?
Yes, sir. So the first step, as we all saw, is that with the awareness that we have created today, at the national level, any neonatologist or a pediatrician who has a suspected baby who is within the first month of life, based on Roshan's criteria, we would get the message through the hotline number that we have floated since last 1 year. This is the number. It is a 24 hours WhatsApp number. Anyone can just post and we hope to respond to it at the earliest. We have doctors on this line 24/7. And following this, we would communicate with our genetic team and the expert panelists, that is Roshan, Uma Madam, and Shankar sir. And they would guide the physician to do the initial workup. And if needed, if, for example, the sepsis is ruled out, then we would go ahead with the testing for metabolic screening. And if needed, the next level of genetic testing. And as Sir has mentioned, the MOA has already been running. We have nearly around 20 families who have been supported within Kerala and outside Kerala. And we were able to reach out to them and we were able to get diagnosis, whether it was a positive or a negative. And regarding the treatment part, like the initial treatment and primary care has to be ongoing, and that is the onus is on the primary pediatrician. We would only be acting as a helping hand to them. And once the samples are approved to be taken, the labs, that is, we have two labs, the metabolic lab and the genetic lab, they would run to the hospital. If given the clear details of the hospital address, each of these all over, that is, the lab has promised us that and the entire national, they have cells where they can pick up, and they would reach there after the approval within 24 to 48 hours and try to get it and start sampling. This would go through the same process of consent that has to be taken by the primary physician. Parents will be talked to, the pre-genetic and post-genetic counseling has to be done. And that is all being processed through, and we will also guide the pediatrician regarding that. And the next step would be to wait for that is, we will have a standard TAT for metabolic, usually within 7 days, and a genetic testing within 4 to 6 weeks. And following that, official report is generated, and this will be shared with our genetic, that is our expert panel, as well as the treating physician, and then would be forwarded to the family. And any doubts regarding this, the validity, the ambiguity, positive or negative, will again, we will be able to handhold them, and we would suggest what to do next. And as we have all known, we would guide them to the respective centers of excellence. And with the Manoj's help and the NNF team, we would like to increase the number of experts in this and try to reach out to all these families.
Thank you. Thank you, Ajay dear. I'm sure the only question people would ask just now is what is the number? So I'll ask you to post it in the group. And thanks to Manoj, because I had to be very honest that the process of using the help which Rashmi madam was willing to give us, we had a wish, we had a dream. I know myself and Ajay running to people, and even the person who was willing to develop website itself was asking 2 lakh rupees. And we said, we don't have any money, we only want to do something. And then we got the money, we got the idea floated, but still people were not taking enough help. Thank you, NNF and Manoj, to disseminate this information. If more people ask for help, more people will know that there are rare disorders that can be diagnosed, that can be treated. Even if there cannot be a diagnosis and treatment, that itself, maybe like Shankarji said, another 2-3 years down the line, this won't be a rare condition to discuss rare disorders. Over to you, Manoj, and before we close the session.
Thank you so much, Naveen. It is actually, in fact, our honor, the honor of NNF to facilitate help. So it is, we are indebted to you, not the other way around. Before I make some more comments, we have the President 2027 of NNF who has also joined in. So it is 2026, Dr. Lalan Bharti has already joined. So I am sure that we now have a guarantee that it's going to go on for the next 3 years, and I'm sure it will continue. Over to you, Dr. Nimbalkar.
So I had a question. One is, I think, because what Dr. Naveen mentioned, that a lot of help was not taken. So I think publicizing it becomes very important. So I think we can do two things. One, simplest thing is the process which is there. You can make a WhatsApp forward of it, which can be utilized. More importantly, I think we can have standees. We may not make the standees, but we can prepare the backdrop for the standees, which we can request NRF members, or at least
We already had. Sorry, I'll just because the Digi NNF platform which we are going to have, in that there is a sidebar called NNF Help, where any member can log in, and if you are a member, then all the details will be available there. But however, as you said, we need more because the idea is to help more babies. So we will take a call and the further suggestions actually. So we would invite people for further suggestions.
So
Please continue.
the standee, what I was suggesting was, can be placed in at least the ones, the NNF accredited centers at least. So even if the doctor forgets to tell, somebody sees the standee, they know that something like this exists. So people, it kind of goes even more further. So I think using that opportunity would be a good idea. And for all the neocons that happen, etc., we can kind of make sure that it is publicized during the neocons and maybe even pediatric conferences, if possible. So those are my two words. And I
Well
had a
said,
question.
sir. These are very valid. This thing, I mean, we will definitely do this actually.
This is more about spreading it, but I had a scientific question in the sense, and maybe Uma maybe can answer it. So what I've seen, because since the abortion date got postponed beyond 20 weeks to 24 weeks and beyond, a lot of birth defects that get detected are coming up for abortions. So are we seeing it that in this particular space of metabolic disorders or etc.?
What I understand from your question is structural anomalies of the fetus. So coming in for abortion, I would say that only very few metabolic conditions present with structural abnormality or dysmorphism. So say, for example, like pyridoxine dependence issues can have corpus callosal thinning, but it is not a major structural anomaly which is detectable. Sometimes extremes of multiple sulfatase deficiency can present with what is known as novel Oxer syndrome, which can present as fetal malformations. But by and large, metabolic disorders to diagnose without the index child in the family as a prenatal is difficult because they do not really show up as structural abnormality. Like,
Yeah, so the
not
question was,
ketotic or peridox independent. What we do in the antenatal counseling in terms of perinatology is like if there is anything which is showing up in the fetus and they are consanguineously married and we are going to do a amniocentesis for the couple, in terms of like on top of offering karyotyping or carrier-seq, we also offer rapid exome sequencing where the turnaround time is only around 10 to 14 days. So it can be a trio sequencing because sometimes we get caught with a variant of uncertain significance. So we kind of offer them a cryosequencing where we have the fetal sampling along with mother and father to make it as a complete profile. And we take an informed decision based on that. Viewers, we need to be really careful, and they need a proper pre-sampling genetic counseling to kind of tell them that what this variant is, because this is not a baby who is already born. It is a fetus, so we need to be really careful in handling viewers. I do not know whether I answered your queries partly.
Any more inputs on this? Thank you, Ma. Any more inputs on this, Professor Onna, Professor White?
No, I totally agree. The vast majority of inborn errors of metabolism do not present with structural anomalies. And so unless we have had an index case in the family, which then alerts us to the genetic predisposition, which is often the case, particularly with the autosomal recessive conditions, we would offer genetic counseling. We would offer genetic counseling, amniocentesis to those families, and they will often choose termination for subsequent pregnancies. But a first pregnancy, it's very rare to make the diagnosis in the antenatal stage.
The only thing I can add, I can only add one thing. At least in our area, because of the high consanguinity rate, and as I said, we know by tribes or by family names, so we do offer carrier status checking testing, which means that if people cooperate and you know that you and your partner are actually both carriers, then you can offer them. Except for that, most of the inborn errors of metabolism, unless you have a high drops, which could be in some of the lysosomal storage disorders, most of the other diseases do not present in utero, except for maybe non-ketotic hyperglycemia, which we know that they like ceasing already in utero, but the others do not present at all. So it's only by the previous one or knowing to be carriers. And then we offer them genetic consult.
Thank you.
I also would like to add on one thing. Like sometimes if they are kind of coming for a pre-pregnancy counseling, then as Professor Orna was telling, like we do offer them extended carrier screening, which would include whole exome sequencing along with MLPA, which is SMA, because SMA is quite common in the population. So we do offer them that. So that is one thing which I wanted to add. So interestingly, there is a Faroe Island where like instead of doing something like an astrology match, they do a genetic match, and they are not allowed to marry if they are carrying the same genes. So it is just for permission.
So interestingly, next month is, I think, birth defects awareness month, as far as Government of India is concerned. In the US, it's January, in India, it's March.
All right. So I think, shall we close now? Because I think most of the questions in the question answer box has been answered live. So now, as we come to the end of this session, I have great pleasure once again in thanking all of you, the panel of distinguished faculty who have joined from various places to contribute to the cause of the newborn, and of course the people who made it happen, the Kim CSR health team, and the chairman of the committee, Dr. Naveen Jain, and all the people. I do not, there are too many names to mention. So like the whole team of the help project who have made it happen. And I also would like to thank all of you respected attendees who have been with us in this session, in this series for since June 2020. And I see so many of your names who are there in most of the sessions all throughout. So thank you so much for joining. This was a slightly different session where we had a slightly execution of a project as the topic. and of course, on the way, eve of the World Rare Disease Day. So with this, and again with a humble appeal to all of you, kindly spread the word that help is available in the form of help project. Details are available with most of the people whom you know in NNF office, or if you don't know anything, just type dgnf.com after March 2nd and you will get help. So with these words, again, with all your permission, I close this session. Thank you so much, everyone, for joining today. And let us continue to champion the cause of newborns wherever in the world we are. Thank you so much.
Thank you, Manoj. Thank you, NNF.
Thank you.
Thank you, everybody.
Thank you. Bye.
Thank you. Thank you. Thank you so much.
Thank you,
Thank
Professor.
you, all.
Thank you, White.
Thank you. Thank
Thank
you.
you. Maybe I contribute next time.
Yeah.